Mr. Chairman, ladies and gentlemen, I've been to Russia many times, but I was never here to attend the Congress on Mental Health. We were speaking about psychiatry and mental illness, forgetting that even if we cured all people who have mental illness, we would have only cured 10% of the population. It's the other 90% where mental health is of tremendous importance. And I would therefore like to congratulate the organizers for bringing this topic to the fore. I am amazed and impressed by the fact, which I haven't seen in other countries, that 4 ministries are collaborating. This is, for anybody who has ever worked in bureaucracy, a tremendous achievement to get the ministries to do something together. Not only 4 ministries, but also 14 non-governmental organizations. A major success and an extremely well-organized Congress, and I congratulate the organizers and thank you for inviting me. I have been thinking about what I should say today, and I felt that perhaps the most useful thing would be to remind you of the context in which psychiatry and mental health promotion has to function. The context in society, the context in medicine itself. And I've listed some of the things that seem to be particularly prominent. I put the number 1, a word that you will not find in the dictionaries. It's a word that has been invented by the World Bank. Commoditification is a word that means that everything has to be taken as a commodity. Health is a commodity. You buy it and you sell it. There is nothing that is not a commodity. And the bank says, if you want to promote health, we have to demonstrate that it has a financial effect. Now that has turned medicine from being an ethical imperative to being an economic opportunity. It's a dangerous and terrible thing, but it's happening worldwide. The second change that is in the environment, and that is of course seen everywhere, in the way in which drugs are prescribed. There are countries in Europe in which you have to start with the cheapest drug, even if your medical knowledge tells you that another drug may be more effective. Because it's cheaper, you have to start with that. And only after 3 months of treatment with that drug, you have the right to prescribe a more expensive drug. Would you do it to your mother? To treat her with a cheaper drug first? And the same is true for so many other things that are now calculated. And the success of a hospital is expressed in the amount of money that it has produced, not in the number of people who perhaps live better than they lived before they entered into this hospital. The second change I think that is important to remember is that the world is changed in its demography. The number of people, elderly people, has grown so much that it now is quite obvious that the whole structure of society is being deranged. And we are not quite sure what we should do about this. Today, about 50% of the widowers and widows in China, in Beijing, have to hire somebody to look after them when they are old, even though the law prescribes that the parents must be looked after by their children. The children risk financial punishment, but still do not look after their parents because they simply cannot afford to do it in terms of time. Demographic change has also changed our appreciation of children and adolescents who suddenly have become much more valuable than they were before in many countries. Now, the third change that has happened, I think, is important, is the change of the class structure of society. In most countries of the world, there has been a significant growth of the middle class. That carries with it a variety of consequences. The middle class, even in poor countries, can afford private health care and does it. Today, the middle class in a developing country such as India is huge. The middle class in India is much bigger than the middle class of the United States of America, about 300 million people who have created a private health care system which is completely different from the system that is provided in the government. This medicine at 2 speeds and the impact of private care is unfortunately neglected by most of the public reports that we see. We see the number of psychiatrists, but we don't really know how many of them are in private care. And the information from the private care system is considerably less good and less clear than the information from elsewhere. Another major change in the surroundings is the change in terms of urban dwellings. Today, there has been an increase of urbanization worldwide. That has been happening for a long time. But what is new and extraordinary is the speed with which urbanization progresses. Today, the most urbanized country in the world is Argentina. 90% of the population live in towns. But that's not the main point. The main point is that these 90% into Argentina have come into town in 10 years. And it has completely changed the nature of the urban setting. People who have come to the town, they don't know each other. The notion of a town community is a nonsense. Nobody knows what they're talking about. And I think that that huge growth of urbanization is, curiously enough, not attracting sufficient attention of the health authorities, so that we have an outstandingly good document in the Alma Ata Declaration, which has been mainly concentrated on primary care and on rural health, in a situation where there is not a single universally accepted document on urban mental health, or ways in which mental health in a town such as Moscow can be provided. We don't know how to do it. And that is, Moscow is still a small town compared to Mexico City, for example, or to some of the cities in China, etc., where the huge number of people imposes a certain style of healthcare which we have not foreseen and which we do not know how to control or evaluate. I do not want to speak too much about globalization because people have done a lot about it anyway, except to say that globalization is not only a process of goods moving from one place to another, but also of value systems that are being imposed upon countries worldwide. One of them is particularly important for psychiatry. We in psychiatry promote and proclaim that it's very important to create human relations, make people depend on one another. And that principle of interdependence has been very prominent and present in most of the developing countries of the world. It is currently being replaced by the emphasis and value given to independence and autonomy, both concepts that are very much against any type of social capital. And so social capital is in fact shrinking. Social capital has been defined as the total of good things that people do to one another. When you help somebody, you are contributing to social capital. When you are trusting other people, you have a high level of social capital. The measurement of social capital published recently show a steep decrease over the last 10 to 15 years, where the amount of trust between people, the willingness to help one another without money, and things like this have gone down worldwide. Now, that is for the world, but the same thing, I think, is true also for medicine. We have seen major changes in medicine. The first one was the change for the responsibility for health from the government looking after people to the individuals who have now to look after people themselves. It has reflected itself in bad ways in many situations. There is, for example, the immunization of children in European countries have gone down, creating a situation in which epidemics of morbility, of various other diseases are very frequent. Pertussis, for example, is appearing in epidemics because the parents who are supposed to take the responsibility for the vaccination refuse to do so. And many of them will not expose their children to any public health measure. We have shifted the responsibility, but we have not given people the means and the knowledge and the possibility to deal with this as they should be doing. There has also been changes in medical ethics. Medical ethics, which, for example, which is of great importance. Take the example of euthanasia and assistance to dying. In a recent report from Belgium, there were 2,080 people who have been assisted to die. And some of them have been what you would previously expect, people who have suffered from unbearable physical pain for a long time in incurable disease. But there were others which are much more different. For example, there is a person who has changed his gender and became has changed gender, became a transgender, and then didn't like his new gender and applied for assisted dying and was helped to die. There was another case of two brothers. Both of them have been deaf, and they started suffering, and they lived for a long time. And then they were told that they are affected by a disease which will take away their sight, an ophthalmological disease. So they came to the assisted dying, and they were allowed to die because they said, we cannot live in total darkness, not hearing anything. Now, these are limits and cases which are not what we used to have in the typical way of assisted dying. Another one example of change in medicine is the fragmentation of medicine into greater and greater number of specialities. On the way in the aeroplane, I sat next to a person who is a surgeon. I asked him what he was doing. He says, I'm doing the left thumb. I say, you must be joking. He says, no, I'm a specialist for the hand, particularly for the thumb. I said, what about the rest of the human being? Well, that's not my business. I'm looking after thumbs. Now, it's an extreme example, but as you go through what we are seeing as the number of medical specialities, it becomes unclear who should in fact bring it all together for the person who is sick. The Americans have proposed special care managers, another category of personnel which brings it all together. It increases the cost of care enormously and still doesn't provide care as it should be done. But it's happening worldwide. We are relying on apparatus to an extent that the number of people who consult traditional healers in highly developed countries, because they are the only people who listen to them, has increased as well, because they are not willing to just talk to machines and be under the machines. And finally, there has been a significant drop in the number of candidates in many countries, not in all, but in many countries, to enter medicine altogether, and not only that, but also to enter psychiatry. And that has been a much more general trend that has been everywhere, because psychiatry and medicine, in the eyes of a young person, have stopped being a discipline that helps people to live better and became a trade, like many other trades, which can then be judged by the amount of salary that you will have later on. Now, in that context, we have to face certain problems in this year in psychiatry, but also in the field of mental health. First, there are old problems that are now appeared in new form. For example, people with schizophrenia survive into the age of 50 or 60, which means that they are suddenly old as well as having schizophrenia. And in addition, they have two parents of whom one or both are demented. Now, we do not know how to deal with people of 60 who have schizophrenia and the parent who is demented in their care. We just don't know how to do it. And there is a number of other things where the disease has remained the same, but the situation in the world has changed to the degree that we do not know anymore how to handle that particular case. There are also new problems. I think there was an estimation that, for example, the number of people who will get dementia because of AIDS is so high that their number is higher than all the existing beds currently in the whole of Africa. A huge increase of people with AIDS-related dementia. Now, with the new treatments of AIDS, we can postpone it, but we are still not quite sure whether and to what an extent we can prevent the occurrence of cognitive damage, since, after all, the AIDS is caused by a neurotropic virus. And there is a number of other things that are coming of that type as new diseases which are appearing. Zika is the most recent example. The problem that is completely neglected in Europe, everywhere in the world as well, is the fact that most people who have a mental illness also have a physical illness. And we do not know how to handle those very well. We're talking about psychosomatics sometimes. But the fact that people with mental illness die 20 years sooner than other people, and that they are suffering from diseases which are well treatable, are not sufficiently recognized. And the comorbidity as such is so high that the World Health Organization in a recent report estimated that over the age of 55, it is normal to have at least two diseases. That is, most people have more than two diseases. And the American figures show that people with severe mental illness, up to 70% of them, have a mortal chronic disease, of which only 10% to 20% are being treated appropriately. Not to mention a recent study in which we have been involved, looking at diabetes and depression, showing that people who have diabetes have approximately 15 or so % with also of depression, of whom half of them are not recognized. And of those who are recognized, about half are not given any treatment in high-level institutions and excellent hospitals. The third, I think, fourth problem I would like to mention is the staffing problem, which Professor Gabel has mentioned in passing, but which is becoming more and more serious. Because the current situation is that the number of people with burnout run away from services. They run away from services to a large extent. In Switzerland, for example, there are courses for preventing burnout of health staff, and you have to wait up to 2 years if you are a director of a hospital to get a place to be trained, because there are so many people who are aware of the fact that their staff has burnout syndromes which make them unable to work and which make the staff likely to leave as soon as possible. I would see priorities for our next time as are listed here. First, I think that we should advocate for simple preventive interventions, which we are not doing. Take an example of school dropout. School dropout is a huge risk factor. It can be prevented, as has been shown in this country, in Novgorod, in Brazil, in Egypt, and various other places where we've done studies. It's preventable. It doesn't cost much to prevent it. We are not doing it. School dropout is still at the level of 10 to 15% in European schools, not to mention schools in Latin America and elsewhere. And there are numerous other things that we could do, cheap prevention. Most countries of the world have stopped doing regular eye examinations after the age of 8. They are done if the parents are willing to do it, but they are not done otherwise. And most of the children who are ill-sight and don't hear very well will in fact end up as being declared stupid because they cannot follow school class. And I could go on listing from perinatal care to different styles of operating, etc. All possibilities of primary prevention of mental disorders. About 20 years ago, we have published a paper about saying that approximately 50% of all mental and neurological disorders are amenable to primary prevention. And yet, it's still just a word of talking and not much more than is done. I think the second one that I would put is the promotion of self-help and the promotion of mutual help. Dr. Saxena showed on his slide that most people will have to help themselves. Have we taught them how to do it? Do they know how to do it? Do the families know how to deal with this? The program that has been developed in Australia, First Aid for Mental Health, is superbly effective, helping people to deal with mental disorders when they encounter it. But we have been far, far back in thinking about the ways of helping people by elements of cognitive therapy or by various other things to deal with their own problems in a more effective way. My third priority would be to start thinking seriously about how we can support families that look after mentally ill people. We are doing it in principle. We are giving in Switzerland 200 francs or 300 francs per month. Now that's about equal to a dinner for 2 people. A family which looks after a seriously mentally ill person for 20 years, how are we helping them? Can we expect that somebody will sacrifice his life to look after another person without being helped? I think the time has come that we have to think of ways in which we can help the families, support them, and make them not fall apart, as they often do when they have somebody in care. We should also, my fourth area is re-examine the current paradigms of care. Community care in towns today where the communities have fallen apart, that requires a re-examination. We have to think of how to create what has been recently called balanced care with various types of services for various types of settings, because the general rules of everybody has to do one or the other are certainly not possible. WHO's logo and motto that has been so important to think locally is unfortunately not sufficiently implied, because we have to think of a different style. No longer can we prescribe the rules and the principles with great ease. They have to be adjusted to the situation in which we are. Professor Gabel has mentioned the discrimination and the fight against stigma, which I consider after many years as being the #1 problem in the field of mental health. We have to think of ways not only to decrease the stigma of people with mental illness, but also of their families, the stigma that sits on mental disorder, the stigma that sits in the mental institutions, on any medications. Remember the state in which, when clozapine was first introduced, a drug that produces in 1 in 3,000 agranulocytosis. All the newspapers were full of that. At the same time, chloramphenicol was introduced, which produces 11 times more agranulocytosis. Not a word in the newspapers. It's normal that some of these drugs have side effects. So, no newspapers. And I think we have to think about ways of stigmatization. We have done a global program on this topic and seen that in any country, regardless of its richness or poorness, it is possible to do at least something against discrimination of the mentally ill and discrimination following stigma. And finally, I think that brings me to the end of this, is I think that we should advocate the promotion of mental health, seen as a simple task, not of decreasing disease, but as a task of raising the value which people give to mental health in their decision making. Thank you.